Hello, everybody. It's Dr. Eric Balcavage, and we're back for another edition of the Thyroid Answers Podcast. And with me is my partner in crime, Dr. Erica Riggleman. Good afternoon, Dr. Riggleman. How are you?
Very good. How are you?
Excellent. I'm doing great. And I am coming off we're getting ready for the holiday, but I've been in a little dive on vitamin D physiology. And I wanted to discuss vitamin D physiology with you. And so many people, especially those in the thyroid community, those with autoimmunity, are told they need to take high-dose vitamin D because their vitamin D is low, and I've got a major issue with that. No, it's hard to figure that I would have a problem with something, right? But it's one of those things I have a problem with. So we're going to entitle this podcast "To D or Not to D." That is the question. Okay, how's that? Is that good?
Very appropriate title for the podcast. I think this is a really heated topic right now. I think that there's kind of been a divide between the functional medicine realm and patients itself and what they're being told by their medical community that is some conflicting information. So I think this is a great podcast to do, since there's some new research that's come out that people probably should know about and at least keep in the back of their mind, because I think that, vitamin D had gotten really, really popular where, a lot of people were recommending it. It's really good for the immune system. And finally, the medical community has started to catch up. And they're starting to dabble in the vitamin D testing. And we'll explain a little bit later how they may not be fully testing. But I think that they're dabbling and they're just kind of over prescribing vitamin D when they may not understand the full picture in some of the new research that's come out. So I'm glad that you're going to kind of shed some light on this whole topic for us. So why don't we just start out by, explaining to the listeners what is vitamin D itself?
So vitamin D really isn't a vitamin. It's really more of a hormone, or what we call a prohormone. So we get vitamin D, primarily 80% of the vitamin D that we get doesn't come from our diet. It doesn't come from a supplement bottle. It comes from sun exposure. So sunlight hits our skin, converts something called 7-dehydrocholesterol into vitamin D, right? And so vitamin D is then the precursor to what we call 25-OHD, which is kind of like the pre-hormone. So there's really three forms. We have vitamin D in the supplemental or dietary or what we see in the skin, and then we get it converted into the more active forms. One of those is the 25-OHD, and then there's 125-OHD, which is really the true active form of vitamin D. So the skin has to make it via sunlight, and there's been some talk that, well, I'll get into that a little bit later. So the skin makes the vitamin D, the precursor, and then you utilize that vitamin D makes its way to the liver. The liver, with the help of magnesium, converts that vitamin D from either diet or the sun into 25-OHD, which is the main form of vitamin D that's floating around the body. It's really the pre-hormone. It's not quite ready for use, but when the body needs it, it can activate it in the kidneys to what's called 125-OHD, and it's the 125-OHD that then binds to what we call VDR receptors, and the VDR receptors then stimulate, I think when you activate VDR receptors, you stimulate like 913 genes. So vitamin D is really important for a lot of functions in the body. But it doesn't necessarily mean we need to be bombarding everybody with high-dose vitamin D on a regular basis. There is lots of studies talking about vitamin D deficiency and how vitamin D deficiency is linked to autoimmunity, and maybe it's the cause of autoimmunity, and there's a lot of controversy whether it's the cause or associated with. I think we're going to clear up some of that in our discussion today. But essentially, we've got vitamin D from sun, vitamin D from food, from supplementation. It has to be converted into the 25, which is the kind of floating around inactive form, and then the body converts it to the active form when it needs it, which is the 125-OHD.
Yeah, that's good. And I think it's important to make the listeners understand that it's also a fat-soluble vitamin. So that 25% that you're getting from your diet, you have to be able to absorb that. If you're not able to absorb fats very well, let's say you've had your gallbladder removed, you kind of take that whole 25% out of the whole picture itself. And since sun is an important way that we get our vitamin D, and this time of year, it makes it very hard to achieve that, especially when you live in the northern part of the country. How long does somebody have to be in the sun to be able to maximize their vitamin D? I've heard ranges anywhere from just a few minutes to 15 to 20 minutes until your skin gets kind of that stickiness on it. What is the research that you've read? What is that pointing to?
I've read it can be as little as 15 minutes 2 to 3 times a day, or 2 to 3 times a week. So you don't need much. And then the other issue is what is low vitamin D? So we'll have to cover what that is. And is really low vitamin D associated with any problems in healthy people? And what we're seeing is it probably isn't. So they've done studies in people in really high northern latitudes who have low vitamin D levels and have no health issues. They've found people in those northern latitudes in the winter, very little sun exposure, have normal vitamin D levels and have no health problems. And then they've found people in areas where they're still getting lots of sun and they have chronically low vitamin D levels. So there isn't necessarily this big correlation. I don't think it's so much that we're deficient because of sun exposure. I think probably most people get enough sun exposure and vitamin D exposure through diet to sustain themselves. So I think the reason for the chronically low vitamin D is not a big issue, is not as much the issue with exposure or absorption.
I don't know if you see this in your practice, but I'll have a patient come in who, has extremely low vitamin D when we tested. However, they've been out in the sun and it baffles them. Like, how is that even possible? I spend all day, every day out in the sun. I should have really high vitamin D. And I think as we explain, as we get into some more of the details, we'll explain how that can be even possible. I think people assume that, just because they're outside, that's the only form of vitamin D, and that that's going to sustain you as long as you get the sun exposure. And I think that there's a lot more that has been uncovered that we'll get into. So can you explain why? Well, let's start with, what is low vitamin D? What would be the testing route, and what would be levels that would be considered a low vitamin D?
So let's talk initially. I'd say the vast majority of people that are going to be told have low vitamin D are only being tested for one form of vitamin D, and that's the 25-OHD. Most doctors will just run a 25-OHD because that is the most prevalent form of vitamin D in the body. It's the kind of inactive form. It's not quite ready for conversion. The 125 doesn't hang around as long, so the 25 is more stable. So most doctors only measure that 25-OHD, and they're making a justification of high or low just based on that one marker. And unfortunately, we can't do that. It's there, and we'll talk about why here in a little bit. But so 25-OHD, I kind of look at, I think my current range is somewhere around 35 to 52 is the range I use for 25-OHD. And really what I look at is in health, and this has been in some of the literature, that 25-OHD should be about 1 to 1.3 times whatever your 125-OHD is if you're in a healthy state, okay? So if you're in homeostasis, no infections, no chronic stress, no chronic inflammation, your 25-OHD should be slightly higher, about 1.3 times higher than your 125-OHD, okay? So I think the big issue that so many people are determined that they have a vitamin D deficiency is because so many people have chronic inflammation, so many people have chronic infections. Almost every person we see who's got chronic thyroid symptoms has some type of chronic inflammatory, immune, or autoimmune process going on. And under immune inflammatory stress conditions, 25-OHD is going to be converted to 125. So many of those people, it's not that they have a deficiency of 25-OHD. What they have is an inflammatory mechanism that's increasing their conversion of 25 OHD to 125 OHD.
Yeah, I think that that's really important for people to understand, because I think in our traditional medical realm, all they're doing is testing that one marker, and it may be whether that's they don't understand the mechanism, or it's the insurance coverage, or there's, and it seems in traditional medical route that they're always wanting to test the inactive form, and we see this all the time with thyroid physiology, how they never want to test the active form of thyroid hormone. They want to a lot of times look for the inactive form. So I think that getting a full picture and knowing what's active but also inactive, I think is important for that full picture. And so when we're looking at why somebody, if you're looking at those two values and somebody getting, let's say that both of those values are low, what do you think is the main cause to why somebody's vitamin D would start to go? What are let's just say the three main reasons why somebody would have low vitamin D?
So one of those, the three primary things that somebody might have vitamin D would be things like if their 25 OHD is low and their 125 OHD is low, then we would define them as having a deficiency, right? We would say, okay, both numbers are low, and so there may be a problem here. So obviously you could say, okay, do they get any sun exposure? They're a person who's inside all the time. Maybe that's part of it. So they're not getting much sun exposure. That's a possibility. They may have an issue with malabsorption, so they're not getting sufficient vitamin D absorbed. But if both are low, I think probably one of the primary things we have to consider is that they may have a magnesium deficiency. Magnesium is a critical mineral for the conversion of vitamin D to 25 OHD to 125 OHD. So I see it all the time. Magnesium is a critical mineral that we get from our soil. We think we get it from the food we eat and the plants we eat, but if nobody's testing the soil to find out if the soil is rich in minerals, and especially magnesium, then if you eat plants that don't have much magnesium in them, you're not going to have much magnesium. And I do a lot of magnesium testing. I'm sure you test RBC magnesium as well. And so many patients are deficient in it. One, because they're not absorbing it. Two, because chronic stress depletes it. So if they don't have sufficient magnesium to convert the vitamin D to the 25 and the 125, they will both be low. So I would say those are primarily the three reasons it would be low: decreased absorption, decreased sun exposure, and primarily magnesium deficiency.
Yeah, awesome. And so I think the question that probably the listeners are dying to know now is, it's the name of the podcast right now is when to D or not to D is the question. And so how do they know when they should supplement with vitamin D? Since there is kind of that fine line, I think a lot of them are sitting back saying, well, how do I know? How do I know that it's not going to cause more issues? So give us the scenarios of when somebody should supplement with vitamin D, when they should support magnesium, or when they should definitely avoid, the vitamin D at this point.
So I think from a very simple standpoint, if their doctor is going to do vitamin D testing, they have to do more than 25 OHD. So they need to ask for 25 OHD, they should ask for 125 OHD, and they should ask for RBC magnesium. And I guess I should clarify that, because I get that from patients as well, is, hey, there's blood magnesium, why do I need the RBC magnesium? Aren't they the same thing? They're really two different things. Only 1% of magnesium is in the blood, 99% is in the tissues. The body fights to maintain blood levels of magnesium at the expense of the tissues. So you have to take a look at your RBC magnesium as an indicator of what's going on inside the cells. So those three things become critical. If you have low 25 OHD, low 125 OHD, and normal levels of RBC magnesium, somewhere around 6.2 to 6.7, then I would say, yeah, you're deficient in vitamin D. Some vitamin D supplementation can help you, but get outside, get some sun exposure. That's the cheapy way. That's one of the ways your body needs to make it. And then you can take more vitamin D from a supplemental standpoint, but you also need to work with your doctor to find out why you're not absorbing it from your normal dietary intake of things before you start loading up on vitamin D. If your 25 OHD is low, your 125 OHD is low and your RBC magnesium is low, then before you start supplementing with vitamin D, what I would recommend is somebody start supplementing with magnesium, chelated forms of magnesium, to make sure they get more magnesium into the system. Do that for about 30 days, and then retest your vitamin D levels and your RBC magnesium levels. And if your RBC magnesium levels are back to normal and your vitamin D levels haven't come back up with it, then again, you go back to the same thing. All right, let's support vitamin D levels, and then let's look at why we're not getting sufficient vitamin D support. If your 25 OHD levels are low and your 125 vitamin D levels are elevated, I highly recommend against using vitamin D supplementation. And that's one of those cases where you don't need it and you probably shouldn't take it. And I can go through, if you want, we can go through that now, why not to do it. But
yeah, I would definitely explain to the listeners why they shouldn't do it. What could happen if they keep loading the system with more vitamin D?
Okay, so stress, inflammation, infection, any of that inflammatory mechanism, anything that increases inflammation is going to increase the conversion of 25 OHD to 125 OHD. And if it's a short-term stress, short-term infection, it's all part of the process, right? So inflammation, you get to triggering of antimicrobial things to kill the bacteria, to kill the infection, and the vitamin D converts to 125 to shut down the antibodies and to kind of restore physiology back to normal. The problem is when you have chronic inflammation and chronic infection, sustained levels of 125 can create some problems. One, high levels, sustained levels of 125 above 40. Above 42 have been shown to increase osteopenia or osteoporosis. And how many people do you know that you see that say, I need to take vitamin D because it's always low because I need to maintain my bone density? No, if you maintain that vitamin D, 125 D level above 42, the research has shown it'll actually increase absorption of of calcium from your GI tract, but it'll pull the calcium out of your bone. So it'll actually lead to osteopenia and osteoporosis. So that's part one. The second thing that can happen is if you have high 125, low 25, there's a good indication you have chronic inflammation and bacterial reactivation or overgrowth. And for 125 vitamin D to be effective, it has to bind to something called the VDR receptors. And those are the binding sites that do all the work. Well, the little bacteria, those buggers have learned how to shut down the VDR to make it not work. So now you're ramping up, you're converting all this 25 to 125. When it binds to the VDR, the bacteria inhibits that function. It's either inhibiting the binding or it's inhibiting the function of the VDR. So it can't do what it's supposed to do. And that leads to more chronic inflammation and more problems. So again, not going to work in that situation. So if you have chronic infection, it can actually become really ineffective and it can create some other issues.
Yeah, it almost fuel that bacterial infection, which so many thyroid patients already have, whether that's the autoimmune or they're just hypothyroid. It creates that cell danger response and they're already susceptible to gut infections or other pathogens in the body. And by doing that, you think you're doing something good for the immune system, because that's what vitamin D is boasted to be, is, oh, boost my immune system so it can help fight these bacteria. But in the long run, you're actually fueling them and helping them stick around a little bit longer.
Yeah, so we don't, I think that's one of those situations where definitely we don't want to do that. We don't want to be doing that as a process. The other issue is high levels, sustained levels of 125 vitamin D will cause the vitamin D receptors. There's some research to show that it actually makes them less competent. It's kind of like leptin resistance, where your cells stop listening to the leptin signals to say, hey, stop eating. It's like insulin resistance. Your cells become resistant to the insulin signals, because if you flood the system with insulin, the receptors become less responsive over time. Same thing is they're showing with vitamin D. If you have sustained high levels of vitamin D, that sustained levels of 125 vitamin D then make those VDR receptors less competent. They lose their functionality, which then means we've lost some of that natural immune response that we're supposed to be getting from the high levels of vitamin D. So we lose that physiology.
Mm-hmm.
And there's a fourth piece to that, and that is that sustained levels of 125 OHD will suppress the enzymes that convert vitamin D to 25 and 125 OHD. So if you maintain high levels of 125 OHD, then it tells the body, hey, I got plenty of 125 OHD. We don't need to convert the vitamin D to the 25. So 25 levels will drop if you're maintaining high levels of 125 OHD.
Mm-hmm. Yeah, I think those are all really, really important things. And when somebody is actually, let's say that they're in the scenario where they have low vitamin D and they would need to supplement with it,
Mm-hmm.
What do you recommend as a dose? You know, I know the recommended daily allowance tends to be quite lower than what it is to get a level up. What do you start people at if they know that both of those values are low and they have normal magnesium levels? What would be that starting level that you start somebody at with vitamin D?
Well, I'll tell you, I used to go high, you know, based on the other stuff. I might have gone 10,000 IUs a day, but I've really shied away from that. I just think that we're pounding the body with high dose. We have to be able to do something with it. It either needs to be used or degraded. So now I'm back to kind of more minimal standards, maybe 2,000 to 4,000 IUs per day as a more consistent way to bring it up. I think pounding the body with high dose like that and saying, hey, this is going to work. I think I just don't think it works as effectively. Now, can you raise the 25 OHD if you keep pounding the system? Yeah, I think you will. At some point, you'll raise the value, but are you doing the patient benefit? Maybe not. There may be a palliative effect, or you may restore lab values, but have you actually fixed the problem? And you won't know unless you run both 25 and 125 OHD levels. And so you got to really take a look at both.
Yeah, I think that's important. You know, keeping, you know, I definitely don't try to, even if somebody's really, really low, I try not to go over 5,000. I think that's, you know, pushing the limits. I would rather than be on it a little bit longer and take a lower dose than try to just, I mean, I've seen people jump into 50,000 international units per day for weeks on end. And that really is hounding the system. And I think it's an important thing to also note is the quality of vitamin D. Since it is a fat soluble vitamin, a lot of them come in, whether it's a liquid or a capsule form, they're usually in some sort of oil. And some of those oils are, you know, oils that would be inflammatory, like soybean oil, or, you know, I've seen all sorts of weird oils that they emulsify the vitamin D in. My personal favorite is either an olive oil or a coconut oil solution that suspends the vitamin D in. I don't know if you have an opinion on that one.
Yeah, I think when we're talking about having these in an oil-based support product, how that oil is processed becomes really important, right? So if it's heat extracted or heat produced, then we're gonna create damage to the oil. We create reactive oxygen species. Are we going to get the absorption that we want? Are we creating problems? I think that becomes a major issue. So I think low levels probably the best. Even maybe pulsing it every other day. Definitely getting outside, getting some sun exposure, making sure you have you have sufficient levels of magnesium. And the best way to check that is RBC magnesium test. If you're doing high levels, or your doctor's looking at it and your 25 OHD is constantly low, I think this is if you're one of those people, this is one of those things where you really need to go back and say, wait a second, what's my 125, right? If they're both low and you're pounding the body with vitamin D supplementation, then you definitely have to ask for your RBC magnesium to find out if you even have sufficient magnesium to convert it. If that's normal and your 25 is low, but your 125 is high, you're actually creating more of a problem. Mm-hmm. And I've talked to some people who have autoimmune issues like Hashimoto's or MS, and they're like, hey, it's been shown in the research that if I load my body with high dose vitamin D, it'll lower my antibodies. And that is technically correct. It can lower your antibody production, but are you healthier for it? That's the real question. Just because your antibodies go down, that doesn't necessarily mean we address the problem, right? So if we take high dose vitamin D and increase that 125 vitamin D binding to the VDR and down regulating the adaptive immune system, yes, your antibodies will go down. That is true. But are we really having the intended effect we have? The antibody response is part of, in many cases, part of that cell danger or protective response. So is that the best thing? And what we do know is that proper 125 vitamin D VDR activation helps stabilize mast cells. So we know so many people have chronic mast cell activation syndrome, they have chronic allergies, chronic histamine response, histamine intolerance. And I wonder, and I see it in clinical practice, a lot of these people who are taking higher dose, sustained levels of vitamin D, and then you see that they have sustained levels of high levels of 125 OHD. If we're losing the competence of that VDR receptor, instead of that 125 vitamin D stabilizing their mast cells, that sustained 125 vitamin D VDR lack of competency of that receptor then doesn't allow for stability of the mast cells, and we get instability of the mast cells, increased histamine response, increased reactivity, increased food sensitivity, increased rashes, all those things we associate histamine intolerance. And I've seen that in the patient base. So I am really cautious of people saying, hey, I'm just going to lower my antibodies. Yeah, I get it. You're trying to play physiologic whack-a-mole, but we have to consider a couple things. One is the antibody response is a protective response in many situations. And two, just because you've reduced that doesn't mean you've actually fixed your problem, because there are a lot of people that have chronic, you know this, right? There's a lot of people with chronic thyroid symptomatology. They don't have any thyroid antibodies because their antibody side of their immune system isn't functioning well. And it's not until they actually start getting healthier and feeling better that they go, hey, now my antibodies are positive. What's going on here? Am I getting worse? No. Your immune system is just finally starting to balance out. And now we're starting to see what we assumed was going on was you always had this thyroid attack going on. We just couldn't see it because the antibody or that adaptive immune system, especially the B side, was being suppressed.
Yeah, I think it's great information for the listeners to, one, understand the whole concept, but understand that little aspect of it, how it can affect mast cells. Because I mean, so many thyroid patients itself have food sensitivities and mast cell activation, and they know what it is, but there's no way to kind of piece it together. There's so many puzzle pieces, and since vitamin D essentially affects so many processes in the body, and it's related to magnesium, which has so many processes in the body, it can be a web. But you have to, I think, when it comes down to it, you know, we've said this over and over again on the podcast. Testing is so important. We can't just assume. And even just assuming off of one lab. So I think that, you know, it's important for patients to understand, if you think you have low vitamin D, or if you've been told that getting the proper testing is step one to really identify, well, what stage, what level of dysfunction are you at, so that you can get the appropriate recommendations based upon that. So, you know, getting both forms of the vitamin D tested and your red blood cell magnesium levels, I think is step one. And then determining either whether working with the practitioner that understands the values, or, you know, trying to get them on your own so that you can actually go get the appropriate treatment at that point.
Yeah. And I think we go back to something we talked about before, which is normal and inappropriate, or abnormal and appropriate, right? And that is, if you see, when you look at your 25 is low and your 125 is high, right, on a lab report, you might think, wow, that high 125 is abnormal. It's not abnormal. It's if you have inflammation or infection or chronic stress of some form going on, that elevated 125 OHD is normal. The low 25 OHD is normal, or their values based on your lab ranges may be abnormal, but they are appropriate, is what I should say, for what's going on, right? And that is the big difference that we like to talk about in functional medicine versus maybe allopathic medicine. When we see something out of range in functional medicine, we want to understand why and understand if it's a normal response of the body versus just it's high or it's low and we have to kind of hammer it back into range. That hasn't worked with cholesterol. It hasn't worked with blood pressure. I mean, we can sustain life, but we aren't making our patients healthier in the long run. And really what our goal is to understand how the body's working, and instead of trying to work against the body, we want to look at that and say, okay, 25 is low, 125 is high. This is not a vitamin D problem. This is it's a conversion or regulation issue that's occurring because there's some type of bacterial or stress response going on. And really our job at that point is to help our patient understand what is that stressor that's causing that conversion of 25 to 125, right?
Yes.
And I think that's the more important thing to do.
Yeah, I think that that's a great aspect to add. And so as we're wrapping this up, do you have any other final recommendations for patients that you can give based upon the vitamin D, or, final little wrap-ups?
I would say definitely just the key things we talk about with testing. You got to test 25, 125, and you should test your RBC magnesium. I think if you're a patient who's consistently has low 25 OHD, it's probably a good time to stop supporting with vitamin D and start figuring out why it's constantly low, get all the testing done. Mm-hmm. If you're a patient with histamine intolerance, mast cell activation syndrome, I think it's really important that you have somebody test 25 to 125, your RBC magnesium, and have somebody look for signs of inflammation in your blood work and signs of chronic infection. Because there's so many people having mast cell activation syndrome today, so many people with vitamin D deficiency, and I think there's a correlation between those two things and something we really didn't get into, which is the iron dysregulation, but that's for a whole nother podcast that we can talk about.
Yeah, absolutely. Well, then I think I think we've uncovered the whole vitamin D mystery and tried to make that a little bit more clear for patients who may have already been told that they have low vitamin D, or they're suspecting that they have low vitamin D.
Yeah. So to D or not to D is the question. And I think we answered, it depends, right? Good.
I think it depends on, you got to get the right testing to know exactly how to appropriately support it. Right
testing, right interpretation, right? I think both those things are key. So let's wrap this puppy up. We get back to doing some work. As always, if you have any interest in getting some help from Dr. Erica or myself, you can reach us at our offices. You can find my information at rejuvegencenter.com. We've changed the name of our office a couple times in the last couple years, and so we're now Rejuvagen is the name of our office, and we're available at rejuvegencenter.com on the web, Rejuvegen Center on Facebook. We have the Thyroid Answers podcast going, where Dr. Erica and I have these on iTunes and some of the other areas where you can find the podcasts. The Thyroid Thursday videos, you can find those on Vimeo and YouTube, and we've added those to the Thyroid Answers podcast, so that the little short snippets, those are usually somewhere like 8 or 10 minutes or less, just short little things. And if you need to get a hold of Dr. Erica, you can find her at
brainandbodyhealthcenter.com. You can find us on Facebook, Instagram, Doctors Riggleman on YouTube, and you can reach out on any of those platforms.
Awesome. So thanks everybody for tuning in. If you're enjoying the podcast, we've been a little derelict in our duties of getting podcasts out because of different circumstances, but we're going to make sure we're putting our commitment to getting at least 2 podcasts out a month, and maybe we can get a little bit more out. But if you listen to the podcast and have any questions, put those questions below wherever you see the podcast. If you like the podcast, even if you don't like the podcast, go over to iTunes and give us a nice ranking of iTunes, and that'll help us in the iTunes feed. So with that, let's wrap it up. You have a great weekend, and if I don't talk to you before the holiday, have a great holiday season, great Christmas season.
Yeah,
all right.
You too.
You got it. Take care.
Bye.